an equity agenda, and Clemens is going to introduce that for us. Clemens?
It's my great pleasure, thank you, to introduce our duo here, dynamic duo, I may add here. And I wanted to just say that, you know, reaching and working towards equity is an ongoing national struggle. And I think we need to be creative and looking a little outside the box how we get there. And the debate is a very important tool and learning tool. And so it's really my great pleasure to have Dr. Kathleen Clanon and Dr. Jeffrey Suter to be part of this team. And since we don't want to have our parents fight all the time, I just want to add they're really good friends. They know each other and they care for each other. So if that gets a little bit, you know, hairy, it is because they want to make a point. And I think the playfulness is part of learning and part of curiosity and part of making us think. And in that way, I want to invite all of you to be open, to actively participate. And we're really excited to have you, Kathleen. I saw you asking 3,000 people to throw paper at each other in one of the Rhine Wide conferences. So we're really looking forward to have you, and also for you and Jeffrey, also a big thank you to be part of our collaborative and the faculty and all the wonderful things that you do for the HIV community around the country. Kathleen, I'll turn it over to you. And if you want to, we can advance the slides for you.
Yes, please. So thanks, everybody. As Clement said, we're going to approach this as a debate, and it is a playful debate. As we're thinking about sustainability and continuing to move forward with reducing equity, reducing disparities, one of the things that's very important is to recognize different perspectives that even our own team members have. So Dr. Suter and I are going to take a couple of different perspectives on how do we, different perspectives we think people within teams and clinics may have. We're going to cartoon them a little bit so we can make the perspectives clear. So a couple different perspectives from clinics, and then one for those of you who are working at a system level, a little bit of a debate about what is our role as medical providers and within Rhine White. So let's go ahead to the next slide. We're going to do some introductions, and then we're going to look at the issue of how do we define health equity particularly within a clinic. We're going to look at how do we assess for social determinants of health as a way of trying to reduce disparities, and then we're going to look at engaging communities. These are all things that we have talked about both yesterday and during this collaborative. Next one. Over to you, Dr. Suter.
All right, good morning. My name is Jeffrey Suter. I started off working in HIV/AIDS work, doing HIV testing and counseling in Detroit, Michigan, and then moving across the country, well, it felt that way, to DC. And now I'm working with Alameda County after, getting my doctorate degree in community mental health. And I also provide consultation to private organizations. Kathleen and I differ on this fact. I believe we can better use or make better use of academic resources, and Kathleen thinks what Kathleen thinks. I'm not going to put words in your mouth, right? Right. And for me, this summer, I'm looking forward to roller skating with my dog and doing some more hiking. Kathleen?
You're muted.
So I'm Kathleen Clanon, and I'm an HIV specialist doctor. I work in Oakland at the county hospital there. I am not a scholar. I'm a boots on the ground doctor, as opposed to Dr. Suter. I'm a practical person. What can we really get done, regardless of scholarship? He didn't tell you this, but he's a total nerd, a PhD nerd. And I actually am a singer. I'm really looking forward as the pandemic, go nerds. I saw that, Stephen. I'm really looking forward to taking that back up as the pandemic ebbs in our area. Next one.
So today we're going to try our best to reach these three objectives in our debates, right? One of the first ones we'll look at is what can we do to improve health equity standards in our clinics, right? And some of that could be reflective and some of that can just be a knee jerk. What do you think are some of the better approaches to improving health equity? For me, that starts with knowing what the definition is, right? Another objective we'll be talking about is addressing social determinants of health in our clinics, right? What are some of the limitations in those roles? And the third is deciding what we should, or how should we address social determinants of health in the clinics, all right? Next slide, please. So for me, because I'm a nerd, I like to start at the beginning, right? Like, which is, what is this definition of health equity? Just Google searching health equity definitions, you'll get like a million different, responses, right? Like, and here are some of the more widely accepted ones. But for us, it's important to also know, like, which one do we identify with more closely, right? So you have health equity is defined by the absence of unfair and avoidable or redeemable differences, right? Like, that's the World Health Organization. And then you have what Kathleen prefers, the patient engagement. Hit one because it's shorter, right? Health equity means all patients have the same opportunity to achieve wellness. That's really simplistic. I don't know what that means exactly, right? So in the chat, if you all could put which one do you stand more closely with, or which one do you identify with more closely, we would appreciate it, just so we can see where people are. Kathleen?
Let's go ahead to the next slide.
All right.
So round one of the debate, ding, the bell goes. What does health equity mean in a clinic setting? So we looked at what different definitions that people have used out in the world of academia. What does it mean when you're trying to implement it or do something better in a clinic setting? Next one. So here's the real truth. I'm going to be straight with you here. We all know our job is to focus on medical care in the clinic. That's our role. That's our expertise. Health equity and social determinants, they're system level problems. Our job is to focus on what's really under our control. HIV care is already really complicated. It's hard to do well. We have plenty of improvements to be able to make using our QI tools on, for instance, preventative care, making sure people don't get colon cancer, rectal cancer, improving their cholesterol, all of those things, making sure healthy aging happens. This social determinants of health stuff, it's all a distraction from what's our real and difficult and primary role. No one else is going to do that but us. So we got to make sure to reserve our time and expertise around that. So our focus should be on ending the epidemic. The focus on equity, it's critical, it's serious, it's laudable, it's necessary. It's not our job specifically. And by the way, how do you think our patients really understand this whole social justice charge? They don't go to the doctor expecting to be asked a bunch of these questions. So let me turn it over to Dr. Suter to see if he can make any real arguments in contrast.
So in contrast, I think the first thing that we should start off with is, what is our goal, right? Like, are we treating just the physical body, or are we treating the patient as a whole person, right? And in order to do that, you do have to have some type of health equity standards, right? Whether or not it's the same standards across boards, or whether or not there's flexibility, whether or not it is meaningful to the patient, that is a place where you want to start when you're assessing, right? And so, although Kathleen has been working boots on the ground and head in a little tunnel here, because she's focused on saving lives, right? We are focused on saving people, communities, loved ones, families. That's more expansive, right? And so you want to have a health equity standard that this community also identifies with, right? Not just a standard that we get from somebody who did a presentation before the weekend. We love those presentations on Friday, right? But we want to get a standard that when we see our patients in our community and they are telling us what's going on with their lives, that it is a health equity standard that they can also identify with as a goal. All right, and so then the question then becomes, do you agree with Kathleen, who is quite lovely and always has a lot to say? Or do you agree with this handsome gentleman here from Detroit, Michigan, who is out here trying to give it his best shot? If you agree with Kathleen, please put Kathleen's name in the box. And if you agree with Dr. Suter, please. Oh, that was so sexist, I felt, right? Because it was like, then please put my name in the box.
All right. I can see the way the wind is blowing here. Let's go on quickly to the next one.
So these are some of the historic ways that unconscious bias has impacted the quality of care, HIV care, due to the lack of health equity standards, right? There tends to be a lot more focus on deficits and disease and not strength and recovery, right? There tends to be an exclusion of family and community when that could be opportunities to help heal and also transfer information that can address somebody else in the community as well, right? We sometimes drive family away just because it can be difficult to deal with them plus 20 patients, right? And social determinants of health are often talked about as negatives, right? Like more so focused on what someone does not have as opposed to the strengths that they do, right? Next slide, please. So here's round two. What are the limits of the roles of clinics addressing social determinants of health? Next slide, please. Right. So when it's focused on the consumer as the identified goal, right, some of the limits when it comes to, determining social determinants of health could be like, it's hard sometimes to get patients to talk freely about other things that are happening in their lives, right? Like they just come in, they want to get their medication, they want to refill, and they want to hit out the door, right? Like instead, we're not talking about what is making them so anxious, because they're not talking about like, they have to worry about if they can get a ride home. They have to worry about if they can get to the pharmacy on time, how long this might take to get into the mail, right? Like, is there a copay, right? Like all of these other concerns are making them unavailable to be present when we're trying to focus on their identified goals, right? And our job is hard enough without adding this group of challenges with limited resources that none of us are all equipped to deal with on a day-to-day basis. We already have a stressed out system. Why add more? Next slide, please.
So our goal really is ending the epidemic. I do think that social determinants need to be addressed. And then the question is, if not us, by who? So Dr. Suter here has kind of flipped the script on us. Now he's saying, I agree, doctors sometimes think they can do everything. And he knows as a psychologist that there's expertise in other areas. So this is really, it's an expertise also to talk with people, to get them to talk to you, to understand all of these different assessments that we have. Do we have the expertise to be able to really do a good job for our patients of assessing them and of addressing these things? Housing is hard, it's its own discipline. Mental health is hard, its own discipline. Same thing with addiction. I totally agree that we over assess. And sometimes our answer to a problem is let's add a required assessment. And that we don't tend to ask people our patients, what are your number 1, 2, and 3 issues? And let's make sure that we address those before we get into all of our different assessments. If we address people's needs that they tell us first, and then show them we are trusting, going back to yesterday, we trust them to identify what's most important to them, not just trusting all our assessments. And if they tell us food, rent, and transportation are what need to be addressed, let's take care of that before we do the PHQ-9. And then just as a sideline to that, We're not really engaging people's support systems. Their family, however that's defined by the patient, they're really critical parts of wellness and of addressing social determinants of health. So that's also something that we need help from, need help from others, but we're the ones patients are going to trust with that information. So next slide. I think you'll agree with me this time that we should add housing and food expertise to our own toolkit. Or do you agree with Dr. Suter, who thinks that we should be referring out when people have housing or food needs, because that's really, other places are where the expertise is. Go ahead and put my name in, go ahead and put the name of your choice into the chat. I think we can linger here for a while because I think you're maybe right, Princess, that this one kind of is a both one, yeah. Sorry, I fell out of character there for a minute. I'm liking
No, it's
this.
okay. I knew you would give in. That was okay.
Okay, let's go ahead on to the next one. Round 3. So this one is, because we know not all of you work, strictly speaking in a program or a clinic kind of setting. So how do we, given all we've talked about over the course of this, collaborative, what are our obligations as programs, as Part A's, Part B's, to collect really community improvement, community input rather, into our quality goals, and have those have an impact on what it is we decide to focus on. So next one. So my argument, which is the correct one, is that our job is to focus on medical goals and not to do community surveys and assessments and that kind of stuff. Patient engagement is important. It's really effective. We should focus on finding out from our own patients, the people we're directly working with, and the community is not our patient. The patients that are in front of us are the ones that we should be focused on. So we should be working one by one with patients, help them reduce their risk, have a better medical outcome, whatever it is that they're doing. There are public health departments out there whose job it is to do social marketing, to do, to do community needs assessments. That's their job. We should leave it to them. And then there are planning councils that exist specifically to get people living with HIV to get consumer input into these issues. So I think you'll agree with me that although it's important to get community health, we should really be focused on the input of our own patients, the people that we're working with directly. So I'm going to turn it over now to Jeffrey on the next slide to attempt to refute that argument.
Thank you. That was such a warm introduction, Kathleen. I appreciate that. Right. And my point of view is, something my mama used to say all the time: only a fool will do something again and again and expect a different result, right? So, this is a strategy that we have tried before, where we worked in silos. And how successful are we? Right? But I will tell you, when we include the community into the work that we do, we get successful programs like You, right? You get successful programs that help connect patients to care a lot more quickly, right? And once again, because I'm a nerd, we should also do a better job of involving academia, right? So when they come out and they want to do research in our community for whatever reason, they need to give us an end product. I think that's only fair to ask. Not a report that tells me what's going on, but an end product that shows me what type of programming would be effective in meeting the needs of our community, right? And I don't think that we should allow them to come into the community until they're able to do so. That's just my opinion, right? And so those are two very strong points of views, right? Next slide, please. And I just want to make the point to say that I'm usually right, right? That's just the way that it has been most of my life, right? I don't imagine that to change. I invite you all to get on board, right? This approach to working with communities in a more inclusive way will do a better job at addressing health equity standards within our respective communities, right? And then you have Kathleen's approach, which is, keep your head down, get your work done, boots on the ground, we take charge, one patient at a time. We're not asking Kathleen to do the community work. We're saying that our systems need the infrastructure to do the community work, right? So if you agree with me, which is the better choice, duh, right? Like, then you'll say Dr. Suter, and if it's, Dr. Clanon, we'll let Dr. Clanon have one or two. She should have one or two, y'all. Y'all just want to give her one or two. Next slide, please. So Kathleen, do you want to?
No, go ahead. Go ahead,
Okay.
Jeff.
All right. So we know that time is precious with this group, and we appreciate you all being open to our playful debate. And sometimes I could be a little snarky, but that's just my winning personality. So I should see a lot of Dr. Suters in the box, right? But sometimes, talking about these topics can be really, really difficult, especially not knowing how people might respond, right? Like, so we'll appreciate if anyone has any reflections or reactions to what we have shared, and any insight to how we can do things differently.
Can we pull down the slides so that Dr. Suter and I can, yeah, thanks. There were a lot of really powerful and smart things people were saying in the chat. And of course it's hard. It's really hard to follow. I wonder if Clement or Barb or anybody, were there particular things that you wanted to pull out? I've known Adam for a long time, so I feel comfortable calling him out. That he made a comment early on about the fact that we don't, as HIV clinics, typically engage families. That's something I feel strongly about. And I wonder, Adam, if you would unmute and talk about it a little bit, and then would love to hear from a few other people about what came up.
Yeah, absolutely. First of all, fantastic, friendly debate. Both of you, amazing job. So I just want to put that out there. And I thank you both for bringing up the critical role that family and community play. My experience has been that the assumption was we don't have family or community, and that we're these islands of beings who are so destitute in our HIV diagnosis that who would love us anyway, right? I mean, that's how I felt about it. And yet, the more I engaged with my community, the stronger I got, because I met other people who had HIV. But then I also met other people in my community who were like, oh, little gay boy, how did we miss you, right? Like, how did you not have the elders or the mentors that you needed, because the world was more complex than you thought it was. And that's just the fault of youth, right? And so I think if folks had connected me, or at least asked about the strength in those spaces and places, they would have found that I come from a strong family. I come from strong elders that were available, that I just didn't perceive as accessible. So thank you for bringing it up, because I think it puts strength in a place where many of us find it. And it's often invisible, I think, to our providers who try to figure out how do we create community for people with HIV when we're finding it left and right if you just look for it in the right way, I think.
Thanks for that, Adam, and for being willing to step forward. Barb or Clemens, any other comments that you thought that we should call people out and ask them to talk about? Oop, Jamie's got her hand.
Well, I want to say thank you to Amelia and the in the chat. They're highlighting that these discussions come up in our team meetings and in our clinics, and these discussions dictate, funding or resources or, staff FTE time and all these things. And so it can actually be emotional at times, or less playful and friendly. So any tips or thoughts from either of you two on how to navigate this opposition or difficult dialogue when the mood is not playful?
I'm sorry. Yeah, I don't know how to navigate it, right? But what I do know is I have a relationship with Kathleen, right? And I trust that regardless of any rupture, we will come back for repair because we're invested in one another in that way, right? Like, so I'm fortunate to have that relationship, but in other settings, I don't always do as well, right? And I just have to accept the fact that this is a process. It's messy, it's clean. I might be wrong, rarely, right? But this is life's work. There's no way around it. And each time that I walk away, I know that my relationship is better because of it, right?
Yeah.
Kathleen, do you have a quicker way?
No, no, but I didn't want to repeat what you said, Jeffrey, because it was perfect. But I did want to just harken back. Remember during Dr. Mate's talk yesterday, I'm sorry, I can't remember who it was, but someone among us said, yeah, trusting your colleagues, trusting each other is also, just as he was highlighting the need for us to show trust to our patients, that trusting our colleagues is really important. And I think that's just making a line between what Dr. Suter said back to what was said yesterday. It is the stuff.
And Lori has her hand up.
Yes, and so I'm the one, Kathleen, who's watching the chat for you guys today. And one of the things, and I think it would be really helpful for Chinny, if you're willing, Chinny, to come off mute and talk a little bit about this conversation being difficult, because I think it ties right into what we were talking about here and the need for like that open-mindedness. Do you want to share a little bit more about your perspective on this?
Absolutely. Thank you so much, Lori. So it's just like we said, I think the best approach is the approach that we've had here today, where both of them know that they have strengths on their side and as well as weaknesses, right? And so it's a process. It's not about you. It's not about how you're doing it. It's not about you want to. So we agree that our ultimate goal is we want to work with this patient. We want to help this patient. And so when we agree on that, then we realize that even though the process is not perfect, what is the best approach, and what can I learn from you, and what can you give, what can you teach me? So both parties, or all the parties at the conversation, always have to be open-minded, where we're not thinking that we're not being defensive, so that we're hearing what's being said and we're learning from it, so that the next individual, the next person we're working with, we're doing things a little better. And I think that's how we just continuing to improve, and that is how we continue to make this space better for everybody, especially our patients.
Well, this is Greg from Here's to Life. One of the things that I've identified in our process is the importance of strengthening, and I use the word enhancing our memorandums of understanding with our agents to address the social determinants of health. Because what's oftentimes happen is that you have people that they get a God complex, and they think that they're supposed to solve everything for the particular individual, and it becomes overwhelming. Whether you're trying to get a background check for a person or get their ID or something, but it really is looking in the community and identifying people with that's what they do, that's their baby, and being able to have a strong memorandum of understanding so you can pass them over to that particular organization and let them do what they do well. So we can take a lot of that stuff off of our team, so they can just have some fair expectations and really do help the client on the areas which they need to be addressed.
I see we have a hand raised from Dustin. Go ahead, and you'll need to unmute yourself.
Thank you. I just wanted to share a couple quick things. Thank you both, Kathleen and Jeffrey, for the fun and playful conversation, but definitely very thought-provoking. And obviously, I think most of us agree that social determinants of health are a real thing, but I think it's also, we become quick to assume, like, if we have a Black patient, that like, oh, you are dealing with like these things, and kind of like just start putting them in a box of like, like basically like, oh, here are the things that I know you're dealing with, even though like I don't know anything else about you. And so even though we know that these things are real, like kind of in the aggregate, statistically speaking, we shouldn't be quick to assume like how it's impacting individual people. And I think it's easy to do, especially when you're like sifting through data and extrapolating meaning from that. It can be, I think, really easy to do that. And then I think the other kind of on the conversation of trust, it's like really difficult because I know at San Diego County, we had an issue where we were trying to like increase our diversity, equity, and inclusion work and kind of expand that. And it became really contentious and it divisive in the sense that like there were people that were just adamantly opposed to it. And like it became like, oh, well, we're going to go to the news because we're spending public dollars on things that we shouldn't be spending public dollars on. And like, I was thinking about that a lot yesterday as we're sitting there talking about trust. And it's like, there are people that it's like, I actually don't, or like where the rub is, like, it's hard to actually trust that you actually have the best interest of people in mind because you're unwilling to listen to either them or others and acknowledge that there are other things that can impact these people's lives other than what you think that they are. And so like obviously I think most of us want to be like optimistic about like trusting and like looking for the good in people, but like I think personally I tend to go more towards the pessimistic side anyways, but like it is like there are people that it's like harder to work with or like they're unwilling to work with you. And then that, but like kind of like how you navigate that. So sorry for the rambling, but.
Thanks so much, Dustin. Let's go to.
Are we done with our presentation, Kathleen? Because I thought we had one slide.
Well, we do, but we have 10 more minutes, and I think the discussion is more important than the slide. So. Okay. Lori's in charge. She's going to call on hands, and she also was trolling the chat for us.
All right, thanks. So let's go to Gregory, since Gregory has his hand up.
Thank you. You know, something interesting, Justin, was just talking about in the area of trust. And I think in a lot of the communities, you know, when you're working with other community-based organizations, oftentimes the smaller CBOs who have a niche, a target audience are vulnerable to the big box agencies. And so there can oftentimes be trust because oftentimes when you link them to the big box agencies, they're hoard clients and it affects trust. They try to integrate them into their system. So it makes it really challenging sometimes when you say, well, yeah, I want to send this client over here, but you send the client over here and all of a sudden now they're caught up into all these other programs that the agencies are using. It affects your trust because now they're taking clients away from you. So I think that oftentimes happens. I'm always leery with the big box agencies and the one-stop shop stuff. So that always puts me on edge in many cases. Thank you.
Thanks so much, Gregory. And, you know, you brought up that point about trust. I want to go to David Moody because David dropped something into the chat. David, can you go ahead and take yourself off mute? Because I think this is a really important piece of, you know, how can we trust? How can we be trusted? How can we trust others if we don't know what the interests are? David, go ahead.
Yeah, I think that you kind of got it in a nutshell. You know, sometimes if there's some mistrust of a system, we try to approach in trying to like address that problem instead of addressing, you know, what's the cause of that, or what is important to you for us to address, instead of, you know, coming at a situation as if we have the knowledge. So the humility of like finding out what are your interests, and then together we can collaborate on what will be in the best interest of you. Does that make sense?
Yes, it definitely does. Kathleen or Jeffrey, do you guys have any response or reactions to that?
I think that's you know, I think that's completely on track and completely true. I wanted, since I got called on, I wanted to go back to a previous thread, just to put in a slightly different direction, which is about, do we trust referral agencies? You know, do we trust other people? And this again is hard. It's not, there's not a simple trick to this, but what I would say is that if people are falling through the cracks and we don't trust this other agency that's in our network, then I think what we have to do is walk toward it. If what we do is cut them, I mean, if you have choices, sure, send your patients to your people to the other choices. But a lot of times, you know, we do have limited resources for referral. And to the extent that we start to make our patients doubt they're going to get services there that are good, or, you know, I think that it is part of our job as part of quality improvement to buckle up, you know, agree that, you know, people at that agency are not in this work to get rich and famous, that they care also. And to walk toward them to say, I need to be frank with you, you know, these past 4 patients didn't go well. Can you engage with us, you know, around why, so that we can actually improve that. So I don't say that, I say that knowing that, you know, it's hard. And I think there's a way that the Ryan White system makes it harder by setting up competition, you know, among agencies sometimes, and people are afraid for their money and some of the things Justin was talking about. So anyway, that was going back to a previous thread, but it looks like it mined another sequence there. So go ahead, Lori, back to you.
Yeah, but real quick, I
right, well,
want to sort of point out that this is where Kathleen is boots on the ground, right? Like Kathleen is not talking about how she has created a culture here in Alameda County where service providers from different sectors are learning to work together for the first time, right? Like, and I think that this is not just a place where she's giving you something theoretical, because she's not academic, sadly. But this is a place where she's able to actually tell you an experiential situation that helped achieve goals and improved quality of care for most of us in Alameda County, right? So I just want to make sure we point that piece out. I'm sorry, Kathleen.
Great, thank you. And, you know, this brings it back. I'm going to ask Patrick Martin to go ahead and take himself off mute, because he's got some threads that really go towards this, the referral, kind of, is it or is it not about trust? Patrick, go ahead, take yourself off mute. Talk to us a little bit about the points that you're making.
So again, when I see referrals, as someone who looks at systems, it's not about whether we trust other agencies. It's how do we make sure that that connection really happens? Often when we make referrals, we think it's going to be easy, and there are a lot of challenges. And so, you know, I consider myself incredibly knowledgeable about health systems, and in my own healthcare, I've gotten referrals that no one ever followed up on. I hit barriers and I'm busy, so I gave up on them. And so my point was really not about, do you trust folks, because hopefully you're referring to agencies you know are going to do a good job, but remembering whenever you make a referral, and they're necessary, no one can be that island, you need to also make sure you have that connectivity between you and the agency, the safety net under the person. And then, you know, I see referrals that happen all the time that you know no one's going to follow up on. But I watch, you know, providers make those referrals because standard of care requires that we do this. And so again, you know, really working with the client to make sure that they're able to successfully navigate that referral, but also whether they're even convicted to making that referral happen.
Patrick. You know, that ties into a comment that Malumba had made as well. Malumba, do you want to take yourself off mute? And then I'm going to turn it back to Kathleen and Jeffrey to see if we wanted to go back to any of the questions. But you were talking, Malumba, about that proximity and relationships. So I think that ties into partially what Patrick is talking about as well. So can you expand a little bit more?
Sure, because sometimes I'm thinking you may have people in the same space, but not know them. You may work together, but not know each other well. So taking the time to get to know each other, and it may seem distant. I'm looking at some of the runway clinics where you have say, oh, the clinic is over here, case management is over here, outreach is over there, but they're not really communicating. Meetings happen, things like that, but there is no proximity to understand and to get to know each other to where they can get at least provide those emotional safe spaces to have these conversations so that you can grow as individuals and find that common ground where you can address some of these issues. And that's kind of what is kind of hard to do, because it's making time and being patient with the different personalities and individuals that you may come across, and just getting to do that. And it's sad that that doesn't happen a lot. And then outside of individual agencies, you also have statewide, where people just talk, maybe you just meet in meetings, but when it comes to really understanding what is going on across on the other side or across another region, you find that there's really not much significance, because they're still not talking and getting to the depth of the issues.
Thank you, Malumba. All right, Kathleen, back to you. And you're on mute.
Can we put the slides back up again? So just one more slide. I really appreciate, let's go to the next one. Oh, no, sorry, this is right, this is right. I just really want to appreciate the depth of discussion that that you have brought forward in this. So one thing I believe what Adam posted, last, which is that relationships are necessary, and we can't just push a button and call that a referral. And if referrals are not working to a particular critical step for people, then I think it's part of our job to actually bring that to the attention of those other people. And to me, the trust is not that they're good at their job even, or that they have the right skills, but the trust is that they want good things, trusting that they also want good things for your mutual patient. And then, working through what it takes to be able to improve. I do think that there are occasional bad agencies, but I think that's rare. Mostly it's that there's not enough of a relationship. So that brings us back then, this is our last slide, that, networks, becoming more relationship focused, both with our patients, formal and informal networks, and also with our, with the networks that we are working with, I think is really important for us to be able to bring this work forward. And as you're thinking, as we move into the afternoon about sustainability, then, I think thinking about how do you make sure that we have a strong network, and how do we bring the patient's network, both the community and also family, more into our work, is kind of what I hope to leave you with. So that's it for us. Thank you to Jeffrey, my friend and debate partner, and really appreciate the extraordinary comments that you all made and the discussion. Thanks, and back to you, I guess, Barbara.
Yep, great.